Hi, I'm Sidney Deckert. This is the final one in a series of mini lectures on Just Culture. This lecture is about second victims. What are second victims? Second victims are practitioners who are involved in an incident that harms or potentially harms other people and for which they feel personally responsible. Now, these are second victims. Of course, incidents have first victims as well, but this talk focuses on second victims. First victims and second victims may have some things in common, but very often they don't. Let me give you an example of a second victim here. Here's a nurse, Kimberly Hyatt, who was involved in the death of a child at a children's hospital 7 months after the incident. She commits suicide. That would be one of the worst outcomes, obviously, for a second victim. But what does the literature tell us about second victims? When you look at that literature, there's been at least 20 to 30 years of work on second victims, particularly in healthcare. What is interesting is that healthcare as a field spends a lot of time investigating the second victim problem, whereas other fields, when you look at policing or firefighting, does a lot of work to actually do something about the problem rather than studying it. Very interesting distinction. But what has been found in that case? Well, if we run through the literature just a little quickly here, 1984, Mizrahi, a very nice study, 3-year study of house officers or registrars or residents. What was seen was doubt, guilt, and you see doubt and guilt that is rife despite the fact that people were able to blame the system for what went wrong. Look, there's all these other factors, it's not just me, but despite that, there's still doubt and self-blame. So there was an insular and self-protective subculture and a lot of self-sentencing going on. That would be a typical result, in fact, for second victims. 1992, Christensen et al., 11 interviews with doctors, essentially reveals that there's a lot of distress after a mistake is made, but that is mitigated by how they feel and how their colleagues feel about how infallible they're supposed to be, which is an interesting interaction that may reflect on how that works in your own field. Fear, anger, depression, all of that was recorded as well. Serembus in 2001, 11 case studies. What was found? Hypervigilance, right? Paying extra attention to a particular procedure, person, or situation. Loss of confidence, guilt, depression, and interestingly, not only a need for support, but an unanswered need for support. Continue, 2005, study among nurses. Saw trauma symptoms up to 6 months after, and in fact, had they continued to study, they may have found it for even longer. And in this case, again, practitioners themselves were able to point to the organizational factors that helped create the incident, and yet there's a lot of self-blame and trauma-like symptoms. West in 2006, again, back to residents, a survey that showed decreased quality of life, burnout, depression, declines in empathy, which is interesting that one of the reactions recorded in that study was indeed a decline in the ability to empathize with first victims, with patients, with others involved in incidents. Waterman and colleagues in 2007, a large study of lots of physicians, and they found that distress is not only limited to serious errors, which is something that recurs in other work and other intuitive experiences with second victimhood. It doesn't have to go really bad for the consequences for the second victim to be really bad. Lack of support during and after the work, and in fact, and that's interesting that this is still relatively recent, that seeking of support was stigmatized. Now, Albert Wu, an internal medicine specialist, wrote up a beautiful paper on second victimhood in 2000, and this quote probably signifies and illustrates the experience, the lived experience of second victimhood. Virtually every practitioner, he writes, knows the sickening realization of making a bad mistake. You feel singled out. You feel exposed. You agonize about what to do, whether to tell anyone, what to say. Later, the event replays itself over and over in your mind, and you question your competence, but you fear being discovered. You know you should confess, but you dread the prospect of potential punishment and the patient's anger. You may become overly attentive to the patient or family, and you may in fact lament the failure to do so earlier. And if you haven't told them, you wonder if they know. This is evidence of lots of internal processing, self-flagellation going on inside of a second victim, and an experience that many may in fact be able to relate to. If we try to systematize the evidence a little bit, what do we see? We see in second victims these sorts of symptoms typically. One is trauma-like symptoms, re-experiencing phenomena, hyperarousal, avoidance behavior, that is typical also what you see in PTSD. And of course the intensity of this can vary very, very much. But also feelings of guilt. Now, how does that express itself? You see self-blame, but also that is moderated by assumptions in the profession, in the person, in colleagues, assumptions of control and autonomy. Professions that assume a lot of control and autonomy over outcomes typically create more guilt and self-blame in the wake of a failure, because there is less possibility to attribute the failure to the circumstances surrounding the person. Charles Vincent sums that up very nicely. He says organizations have an important role to play in this because they help create the culture in which self-blame is more or less likely. He says a culture of perfection in which errors aren't tolerated, in which a strong sense of personal responsibility both for errors and outcome is expected. With that sort of background, it's not surprising that mistakes are hard to deal with. I even have that concern not just for medicine or healthcare, but for lots of other fields. Many organizations are declaring a zero tolerance or a zero vision when it comes to incidents, failures, and errors. Might they also be creating a culture of perfection in which making mistakes is not tolerated, in which personal responsibility for safety is expected of everyone, and that if you fail, that you feel that you have failed the entire organization? That would be the culture that helps people set people up for self-blame and guilt, and indeed many of the symptoms of second victimhood. It in fact makes error a moral failure. There's a literature that distinguishes guilt from shame. I won't get into that, but you're welcome to do more work on that if you want to. Guilt and shame are different emotions. Guilt is more outwardly and socially directed, and thus something that can be used more usefully and fruitfully and collaboratively in dealing with the consequences of an incident in second victimhood, where shame is inwardly oriented and gets people to retract and retreat from view, and they may not want to engage socially. So these are different emotions that play out in different ways in many second victims after an incident. So what does the literature say about the prognosis for second victims? Well, you could summarize a recent part of that literature as this. 3 outcomes or trajectories are really possible. People drop out, they survive and just muddle through, or they thrive. They actually use or are able to convert the experience into something that makes them into better practitioners, better human beings even. Let me give you an example of 3 stories I've been involved in in aviation, where these 3 different trajectories showed up quite clearly. In one, there was an incident that totally destroyed the airplane, but it was an accident in which everybody walked away, surprisingly, because the damage was very substantial. Now, the pilot in that case, where everyone walked away, never flew again after that day. There's another incident that I was involved in where there were about 7 fatalities. The pilot involved was very troubled by this, but was able to continue his profession. And every time he talked about it, however, there was trauma-like responses. It was very obvious that even 20 years after the event, there was a large amount of unprocessed grief and trauma. And then there was an incident in which more than 80 people died. The pilots in that case were able to once again resume flying at some point in their careers and have thrived, do very well with another carrier today. And so what's interesting is that it almost seems, from these three examples at least, that the relationship between the severity of the outcome and the prognosis for the second victim is inverted. But they may not be related in that sense. In fact, what matters, and the literature backs this up the whole time, is social support. How much social support from colleagues, community, organization, peers does the second victim get? That is, the literature agrees, one of the strongest predictors of the outcome for the second victim. How much social support? Lucien Lippe, a very early and important thinker in patient safety, summed it up quite nicely like this. He said, well, most would like to examine their mistakes and learn from them. And from an emotional standpoint, they need the support and the understanding of their colleagues. Yet, they are denied both insight and support by misguided concepts of infallibility and fear. It's the fear of embarrassment by colleagues. It's the fear of others' reactions. The fear of litigation. So culturally, practically, and legally, we put a lot of obstacles in the way for us to, in fact, show the support that second victims need, and that is so critical for the trajectory that they will follow after an incident. If you were to be able to set up such support, what does it look like? Again, there's lots of literature on this, but here is just one way to encapsulate it. You can distinguish three sort of distinct phases in it. The first is diffusion, then empowering, and then a follow-up. Diffusion is immediately post-incident. You offer first aid or psychological first aid to the person involved. This may involve taking them off shift, making sure that they are okay, have enough to drink, can lie down, whatever it is that they need. But you don't really need to or want to get into the content to reestablish what happened. That comes later. In fact, that is the empowerment, or the second phase. You debrief. You help understand and create a narrative of the story and how things could go wrong. And most second victims, in fact, just as Lucien Lippe said in the previous quote, are very interested in learning that, in wanting to know how things could happen the way they did. You may even want to offer them a role in helping to investigate this or offer them to write their story about it, which I've in fact sometimes seen happen spontaneously, people writing up their stories. Some of these have been published even in the medical literature. And of course, interestingly, you might want to consider a meeting with other victims. The first victim who was part of the incident. That takes a lot of planning and care and ethical responsibility, of course. Important then, the third phase is a follow-up. That is, there are anniversaries that are important to second victims. The birthday of a child involved in an incident that didn't survive, something like that, at which self-harm may be more likely. So you want to keep a check on that as you monitor and stay in touch with second victims. In order to set up that support, what do you need to do? Well, there's quite a bit of stuff involved, lots of steps. And again, other organizations have gone before you. And here's some of the things that they ran into and had to sort out, right? Who are the target groups? Who are you actually worried about here? Not just the providers of the support, but also the beneficiaries. Consideration of the legal and the insurance context that follows with each incident. An allocation of responsibilities for finance and documentation, if any, right? Recruitment and selection of supporters, if that is necessary, if you find that that is necessary. If you do want to train them, you want to think about recurrent training because there may be new insights each year that you want people to be aware of and learn. You want to check on their continued capabilities to effectively support second victims. There needs to be some type of quality control of the interventions, right? You want to know that what you're doing actually does help. And you might want to market the program or the ability to support second victims in ways that make it visible and available to those you want to help. So there's lots of things involved in this. What you don't want to do is end up in a space where one of your people is saying this, as reported by Scott in 2009. I didn't know what to do. or who you were supposed to talk to professionally, legally. I didn't know how much I was allowed to say, where I should document things. We've got policies for everything. We have policies if people get a needle stick. But if this happens, you don't know whom to call. I don't think any of those things are clear. I didn't know what to do. If that's the sort of testimony that might come out of a practitioner in your organization, there is work to do.